think everyone's here for our panelists for this third and final question and answer. We just want to welcome everybody to this Case Conversations special edition case in partnership with McKinsey Institute USA and with Brian, the patient. Scott Harbawi was the assessing clinician who also is joining us for the panel discussion as well. And thanks to Dave Oliver, Cora Aitona, and Gary Dykes, as well as Scott Harbawi for meeting with us these last couple of weeks and tonight for this third night. Thanks to everybody for hopping on tonight, taking time out of your schedule to invest in yourself and in your professional development. So we just really appreciate Scott, first of all, for introducing this idea and coming to me and allowing me to have the honor to have some discussion with you guys regarding this patient case. So we look forward to the discussion tonight for this third visit or following this third visit. So hopefully everyone has been able to access that third video. It's a short follow-up. And we've got a few questions that were sent in before, but I will invite those that are listening live right now. If you have additional questions or you are unable to get those in, please feel free to type those in now and we'll try to field any and all that we can. So the third visit was 4 to 5 days later. And Scott, the first question that came in 2 to 3 times was this comment from Brian regarding his soreness. Do you want to address that first? How did you interpret it? And what do you think is the cause or the explanation for it?
Well, yeah, the first thing though, the first thing he said was he was much better.
He did.
And, you always have to keep that in mind there. And I think the thing I'd probably like to say about that is that, I say sometimes at courses, patients are like rabid dogs. They sense weakness. And if he says, oh, my knee is sore, and I kind of just start to focus on that and discount, the fact that he says he's much better, then he starts to worry that maybe this soreness is something that's really a problem rather than it's just something that it occurs when you're moving joints around and have pain. And if I could quickly, I was in Oregon, I think it was earlier this year, doing a course, had a nice woman in her 60s, retired, and she couldn't play golf. They sent her for her back, but it turned out to be her hip, and big problem getting out of the chair. And she needed to do extension in the lunge position, came back the second day and said she was better, but she had a complaint that her knee was sore. And I said, your knee is hurt? She said it was hurting. I said, it's hurting. And she said, yeah, because I'm kneeling on it. I'm putting pressure on it. Can't you give me something else to do? So we tried to do it on the chair and it didn't seem to work as well. And, you pick and choose your spots. And she was kind of a fun woman. And I said, you know what, this might not work as good on the chair. You might just have to suck it up. And I think a lot of people in the crowd were they were, what? So anyways, make a long story short, she comes back the next day and she's markedly better. And I said, oh, the chair exercise worked. And she said, no, I sucked it up. So, if guy says he's a lot better and then he says, well, I had a little bit of soreness. Why are we going to focus on that?
Yeah.
He's a lot better. People will say, same thing, somebody in the lumbar spine centralizing, but, my arms are sore or I got some just general muscle soreness. If you start to focus on it, the patient focuses on it. And it creates more problems than it's worth. What it was, I don't know. I don't worry about things like that.
Sure.
Was it quote unquote localization? I don't know. I didn't dig into it. I didn't ask a lot of questions about it because, again, the bottom line, this guy is much, much better, and let's just go with that.
Sure. Good comments. And before I throw it out to the rest of the panel, just to get other thoughts on it, I do want to make it very clear right now that right now Scott is bringing on the heat. He's now has the most memorable quote as of right now. So Gary, you better get ready. Patients are like rabid dogs. They sense weakness. What you got, Gary?
I have to work on it.
Yeah.
Hey, I have 2 though. He's only got 1.
Oh, well,
tonight is the first 2 weeks.
There's 2 trump 1.
Yeah.
I mean,
well, it's the third night.
For this case conversation, you already had 2, right?
Yeah, I got a couple. Can't push a man up a ladder.
Okay, talk to me about that. What is that? Just a random thought, or?
So if he doesn't want to go up the ladder, if he doesn't want to participate, then you got no chance. There's a
Wow.
participation quote, so you can't push a man up a ladder.
I like it.
We may be
Give it a
looking
try.
at the poet laureate of the Institute here.
I do want to hear from Cora, Dave, even Gary, possibly, if we can't get any
If you
intelligence.
can't get anything else,
That's right.
I'll think of another quote.
That's right. Your thoughts on the soreness? Do you hear that commonly?
Yeah.
And can we be at risk for missing the bigger picture? Cora?
Yeah, so I was gonna say it's not uncommon, I think, for derangements to come back with a little bit of soreness. It's almost like instigating a slight inflammatory response. And again, I don't have a research to prove this, but I tell folks when we treat the spine and then we get centralization, it's not uncommon for people to have transient pains. Don't we talk about new pains, right? So as they're doing new exercises, they're allowed to have transient pain. So we talk about maybe as they're holding their posture more upright, then they start hurting elsewhere. But so I think the most important thing to remember is every visit is a reassessment. So I'm not worried about Brian coming back 2 days later and telling me he's sore. As a matter of fact, maybe the previous visit, I'd probably warn him of some soreness from doing more of the exercises, right? So, but if he comes back, he's sore, then I'm gonna ask him, is this the pain you presented to me with in the beginning? And then I would do another reassessment. Is he losing motion? And if I'm not seeing an evidence of a rederangement, then I'd talk to him about transient pains, and then I'd tell him to go ahead and keep doing the same exercise. So I think the biggest thing is, again, reassessment. Your mechanical assessment's not going to lie to you, right? So patients may come up with different symptoms, but if you're following the system and you trust the system, you should be able to arrive at the same answer.
Yeah. Dave, anything to add to that?
Yeah, I mean, I agree with that. It's, and I say to patients all the time, patients come back and they say, we're doing the exercise and it's better when I'm walking, it's better when I'm doing this, but it's sore. And I always tell the patient, if I pick any joint in the body, and this is an end range system, I want you to push this joint to end range 15 times every few hours and do it and do it and do it and do it for 2 or 3 days. If you don't get some local joint soreness, you're going to be surprised. But I think it comes back, and Scott made the good point. First thing out of his mouth, I am better. Good. But I am sore. Okay, I've kind of, yeah, I'll accept the soreness. I'll acknowledge it, but you got to just kind of move on from the soreness. If he came back and just said, my knee is sore, well, that's when your mechanical assessment comes in. It's like, are you sore? What Cora just mentioned. Is this more of your pain? Are these new pains? And your baseline movements will tell you. He's got a big loss of flexion. He's got a functional loss of squatting. So you just go down the pathway and go, okay, he's already reported he's better, but he's sore. Okay, is he sore because this is the wrong direction? Well, you can clean that up in 2 minutes. And very, very quickly, motion is better, function is better. You know what? It's sore. You're moving. You start to move, you're going to get some local soreness. Don't worry about it. Move on. Suck it up.
Very good. And the relevant quote right now would be, Gary?
Oh, man, I'm out. I didn't know I was going to
Okay.
have another one. 2 in 1 night. It's impossible.
I'm expecting them just for every
Roll
comment
off?
that's made. Yeah, they roll off.
You can't push a man up a ladder.
There you go.
Yeah.
That's the quote for that.
All right, we'll hold on to that for a moment. Thanks everyone for your comments on that, and we appreciate that. You're right, taking a joint to end range. If they're not feeling something, perhaps they're not getting to end range. Maybe,
Yeah.
And it's not the concordant symptom. I guess maybe. Go ahead, Greg.
To add to that, I think that that everyone would agree that, and I start the first day of an extremity course talking about this, is that, guys, listen, we see these people Saturday, Sunday. I'm going to go ahead and tell you, no one's walking back in the room on Sunday going, man, I love you, because I feel great. They're going to come back. They're going to be sore. They get a bit cranky, but is it more of their pain, like Cora was saying, or is this actually something new? And that new something usually walks in on Sunday. I mean, it's just inherently that way. And so I know that I've said that on every extremity course I've ever taught, that be ready for Sunday, but be aware of how the questions go, because it's really about, are you worse with your pain or is it something new? And I think everybody on the panel will agree with that.
Yeah, Great points. Let's talk for a moment. Scott, your first move on physical examination, once you got the data or the information from the history in that first few minutes, you went straight to supine, checking your manual assessment of extension and flexion, and of course asking the patient, what he was feeling at each of those positions or with each of those motions. We've talked about being methodical before. Is that what you do? I'm just thinking, could a clinician test the functional test first, or is there any value in doing one versus the other?
Geez, I never really thought about it. I think I do it just because I'm a creature of habit.
Sure.
We're used to doing, for 30 odd years, I've gone movement loss before I do, repeated movements. And so I just tend to look at it first all the time. I don't think it would be wrong necessarily to do a functional test, although you do have to consider his functional test is loaded flexion. If he did some, and probably not, although sometimes extremities are so rapidly changeable. If he squats once or twice, he could actually rearrange that knee, and then I wouldn't see that I might not see the full motion that he would have in the beginning. He might have reobstructed that joint. So I don't think that's a big deal, but I think really I primarily do it out of habit. That's just what I do.
Sure. Any other variation or deviation from that, Gary?
I tend to be the same way, and I don't know if I think of it the same way as Scott does. I think it is being methodical, and so I always think, okay, let's start from the beginning. Let's go ahead and take a look at the motion, see what that looks like compared to our first visit and what they think is different, and then I'll work back towards that just the same, unless they beat me to it, because there's the occasion they may walk in and go, hey, I can squat. Because they've tested it and they know it and they want you to know it. And it's like, okay, great. Well, okay, we check that box and then move on. So, yeah.
Okay.
But I think I'm the same way. I'm in the same boat. I'll do it the same way.
Yeah. Dave and Cora, any?
Yeah. I think your exam, and just like your follow-up exam, follows the same format. You take a history. So what are the symptoms? Are you doing your exercise? Are you doing as officer I want you to do? What is the effect of doing it? All right, let's take a look at your movements. Okay, let's take a look at your function. And yeah, you kind of keep it fairly consistently. But sometimes if a patient comes back going, oh, I'm so much better, I might sit there. I might just sit there and say, go ahead and squat then. Have a quick test. You've already confirmed direction. I don't think it makes that much difference whether you test it before and afterwards. Ultimately, when they're coming back, you're just trying to confirm that this is a derangement. You've got the right direction, the right load. So if you can check all those boxes, you can move on. And if you can't check all those boxes, then you've got to investigate. But it's best to kind of keep the investigation standard. Just keep it standardized, go through the same routine that you have done all along.
Scott mentioned briefly that extremities can be very rapidly changeable. Can you folks see a patient in your mind that you've seen and realize that I've got to really train this patient to watch out for those directionally vulnerable movements that might rearrange quickly? And is that an issue? Is that something that you guys see, or is it no different than spine or anything else? Cora, you have thoughts on that?
Yeah, often, I would say that the majority of the derangements that I've seen in the extremities tend to be a whole lot quicker to respond compared to the spine. And often you do not really need to stop them from recovery of function. So I think that's one of the differences between the spine and the extremities. In the spine, you're a little bit more structured and you're strict with recovery of function in a lot of the patients. But in the extremities, often I'd tell them, go and play and go do what you want to do. I don't restrict their activities unless they're fragile or they easily fall apart. So the majority of the patients, I would say, are not fragile, the extremity patients. So you can pretty much get their recovery of function going while they're performing their reductive force.
Okay, so Dave and Gary, can you think of a hip patient that showed a directional preference of extension, or a shoulder that showed a directional preference of an extension or internal rotation, that when they went to flex, sit too long for the hips case, or reach overhead repetitively, the patient described or demonstrated a quick a worsening or regression of their progress. To illustrate, I guess, what we're talking about here.
What do you got, Dave?
Not much.
Yeah, you don't see that real common.
I mean, you know, it's, and I think like what Cora was just saying, you know, when I see a patient on day one and I evaluate the patient and I go, okay, you've got a knee problem. You've got all the characteristics of derangement and you've got all the characteristics that you need this specific loading of that knee joint to do this. And patients often will ask me, oh, well, can I do X and Y and Z? And I'm like, well, are you doing it already? Yes or no? And if they're not already doing it, I say no, not until we kind of fully kind of establish that we've got what we've got. And if a patient says, well, I'm already doing this and it bothers me, I already did that and it bothers me, I'll say, okay, well, go ahead and start doing this exercise and continue to do those activities and use the bothersomeness of those activities as a guide whether this is the right or the wrong thing. But I'll tell people, it was like, you know, can I run? Can I bike? Can I do these activities? And I just turn the patient into a self-assessor. And it says, you know, okay, you know, you can do this activity as long as it is not getting in the way of your recovery. And if you turn them into a assessor and you go, okay, well, I'm going to get on the bike now. I've been biking. It's not making me worse and worse and worse and worse. But I've got a knee derangement that's responding to extension. You know, is it good to do lots of cyclical flexion on that bike? Well, let's test it. Basically, self-assess your motion, self-assess your squat, get on the bike for 15 minutes and go. If you get off the bike and you're worse, you can't do that right now. But we're gonna put it on the back burner for maybe a couple of weeks. And then we're going to continue down the path of reduction and maintenance. And then we'll use that functional task and activity as a guide, whether you're now ready for that activity. But I don't see too many people that fall apart rapidly. Yeah. But, you know, and I don't address it, but I guess probably on day one. But, you know, if I'm sitting there and I'm identifying, you know, how you doing? Well, I'm 10% better. You know, then you start investigating, well, what is getting in the way of your reduction and maintenance? And then start kind of picking apart, are they doing something that's getting in the way of their recovery? And then start to pull those things out.
Or were you going to add something?
Yeah, I was just going to ask the rest of the panelists if, because I'm just noticing that those who fall apart rather quickly are usually the ones who do not fully reduce. Like maybe there's some type of structural instability. Is that something that you guys find as well? Because often derangements, they tend to be a little bit sturdier in the extremities. So just like I said, you don't limit their recovery of function.
Scott, you want to comment?
I mean, I've had a few patients, that I would say like that. You know, it looks like you get good reduction in the clinic, but then they fall apart rapidly. And some of those patients that I've never been able to fully reduce them or fully maintain them. But I've also seen patients where it's kind of like 5 steps forwards, 4 steps backwards. You can get good reduction, but then they do something and it kicks back up again. And it just takes longer to bring about full reduction and full maintenance.
Anything else from anyone on the reduction or rapid reversal?
I think that something that and I don't know where everyone else stands with this, but I think with regard to that maybe they can participate in certain things that they like to do, but they tend to, like Dave said, slow the progression down. If they stopped it entirely, they would go faster. Now that they can't reduce, it's just going to take longer to get there. And so it's almost like a lumbar derangement or cervical derangement. You're going to sit at the computer. Well, you're going to sit at the computer and not give it a perfect environment, then you're going to have a longer period than the 2 weeks we tend to anticipate potentially with perfect world stuff. And so I think that that's probably true. And then the ones, Cora, like you were talking about, the ones that, you know, I've seen that are surgical, you know, if you're still scratching your head at about 3 or 4 visits and you can't get something to kind of grab on and go, it's like, okay, you know, is this one of those people that turns out to be potentially a surgical candidate? So that's kind of that.
Yeah.
Is that you?
Yeah, that's me.
This is our interruption and brief commercial break brought to you by the iPhone.
Gary Dykes.
So that's the that's
another great moment by Mr. Dykes.
Yeah, so it's one of those things that the people that I've seen, if I'm scratching my head 3 or 4 visits into it, that it's one of those where it's like, okay, and I go ahead and right up front tell them what we're looking for. Like we've talked about this on all the things. We pre-educate these participants, these clients of ours, our patients, and say, hey, this is what we're trying to do. And they almost know at 3rd, 4th visit, it's like, okay, this isn't going so great, is it? And I'm just like, no, it's not. So what do we do next? And then that's where we start directing care. So,
anything else to add? Let's turn our attention then to. Go ahead, Scott. Yeah, you guys.
Jason, I'm gonna be the devil's advocate here. I mean, I see derangements. I mean, I see shoulder derangements that literally, reduced with functional internal rotation and 3 or 4 repetitions of external rotation with a piece of TheraBand, and they're re-deranged again. And I see that in the knee with people that do 3 squats. And I don't see many people that I can centralize in the lumbar spine and blow them up with 4 or 5 flexion and standings. So I don't know. I see, my sense is, especially in the shoulder, and as long as the loading strategy is weight bearing in the knee and the hip, you can re-derange that thing in a heartbeat. And
even with a patient that's fully showing full reduction, abolished symptoms, full range restoration.
Yes, I can recall the CrossFit people that, and they do a lot of stuff out here laterally, and, they want to continue with that. And I'll show them, we'll reduce it and we'll walk over, and literally, here's a small piece of TheraBand. You do 3 or 4, 5 or 6 external rotations in neutral, and they've re-deranged again. And I think there's a good example of that. Dave, you recall the woman in Syracuse at YouTube. We re-deranged her with 8 or 10 horizontal abductions and reduced her with 3.
And then Gary's video, the girl with the shoulder.
Oh yeah, I remember that.
And again, but I think as well. I mean, I see a few. I don't think I see that often. I don't.
No,
see,
and I'm not saying every patient.
Yeah.
But I see that rapid.
Yeah. I would agree with that. I would agree with that. Especially.
You ever see anybody reproduce their sciatica with 3 or 4 flexion and standing?
Yeah.
I mean, it usually takes a little bit more than that. I mean, so, and it's a tough sell to some of the CrossFit people. Look, you got to stop your external rotation, whether it be out here or out here, and you're gonna have to stop that for a while. So I do have to, at least some of those people find that I do have to restrict that, or ask them to restrict that activity for a period of time.
But are you doing that on day 1?
Yes, I would. I see that sometimes on day 1, because they're wanting to. We get a good result, and they're like, okay, good. So I can start. I can go back and work out. I go, well, let's go check it out. And I don't know what's going to happen, but I go over there. Here, grab that TheraBand and pull it. And the next thing you know, they've rearranged. It's like, see, you can't do it. It's, that cause and effect again, showing it to them.
So, but do you find, Scott, that, I'm not trying to take over Jason's job as the host, but I'm just curious if you see that mostly in upper extremities, though, those who are a little bit more fragile as far as, or do you tend to see it in a variety of joints?
Yeah, I think where you see it most is in the shoulder. And then you will see it in the hip and the knee with loaded movement, not with unloaded movement. You can move them around on the table all you want, and I shouldn't say all you want, but it doesn't change that quickly. But shoulder, I think, is the one that will do that. I mean, literally just 3 or 4 movements and re-deranged again. And I'm hard pressed to ever think of a spine that 3 or 4 movements totally reverses everything.
But I'm just thinking maybe it's multiplanar joints versus hinge joints, because I don't see it so much in knees and elbows. Not that I see a whole lot of elbows, but the majority of the derangements that I see in the knees, they tend to be a lot sturdier. But I would think that in the shoulders and the hips being multiplanar joints, maybe, you'd see that a little bit more. So I think that's just an interesting observation.
Scott, when you do have the patient that rapidly re-deranges, and is it feasible for some of those patients to completely abstain or avoid the activity that might produce that or create that? How do you handle that? Is it look, you're just going to see yourself probably have moments where you regress, we just keep going back to the reductive exercises, 2 steps forward, 1 step back kind of thing? Or are you able to persuade them to say, oh, I'm just going to avoid that motion altogether?
Well, yeah, I mean, I don't think it's any different than somebody with an acute derangement where you say, listen, you need to not bend over for a week.
Yeah.
You know, something like that. You need to limit your sitting. You need to be on this every hour. So yeah, I you know, and it's difficult for people to do that, but you know, I think in the extremities, in some ways, it's a little bit easier because you know, you can avoid functionally resisted external rotation through the course of your day, but in the spine, if you're very vulnerable to sitting, that's a big issue for a lot of people.
Yeah.
Yeah, again, my sense is I see it. I'm not saying every day, but I see it fairly regularly in shoulders.
Enough.
And again, knees and hips. It's when you load them. Now, again, I work with a lot of CrossFit people, and it's like, okay, they want to be doing their squats or whatever, and you take them and go over, have them do 10 or 15 squats, and they'll re-derange pretty quickly.
And then if you tell them to stop squatting altogether, they'll just go to the next therapist down the road.
Not necessarily stop squatting. And with some of them, you can just limit it, say, to 90 degrees, and they're still okay. And that's one of the things we'll work with them with, as far as, okay, this is what you're able to do. Have them learn what their ability is, essentially at that point, how to self-monitor baselines, and you can have them work with that as far so that they can stay somewhat active, not have to avoid it completely. So, okay, you can squat to 90 degrees, but you can't do your deep squat that you might want to do.
Sure. In this particular patient, Brian, would it have been appropriate in visit number 3 to test some unloaded, partial loading, fully loaded flexion to learn if he would re-derange for the value of understanding how much you should educate him to stay away from that squat repetitively or in a routine way? I'm just thinking about times in the past where I think I've heard some of you guys comment how Robin mentioned that maybe we're a bit slow for recovery of function or recovery of flexion. Any thoughts on that, Dave?
No.
Gary?
That's hilarious. You can't push a man up a ladder. I mean, yeah, you know what? And it probably isn't answering your question, but
well, the other quote that you gave us didn't have anything to do with anything either. So go ahead.
I think it's right. You know, just come out. It's just grab it out of there. But I think that going back to what Scott's saying, I'm a lot more willing now than I was probably 10 years ago to have someone that's coming to me that's been to a therapist in the past. These problems are all recurrent, persistent, unresolved, whatever. Most musculoskeletal stuff, if you sit down and get to the nuts and bolts of it, nearly everyone you see is going to have had some version of their problem sometime before. So if you talk about it and they've had some advice or they've looked it up on Google or whatever, and they've got something that they use as a go-to stretch or go-to move or go-to strengthening thing that's worked in the past and now it doesn't work, I am more than willing now to say, well, then they say, well, can I keep doing that? It's like, well, I don't know, show me. And, you know, we'll have set the baselines, we'll have done the key movement, we'll have, you know, clear, you know, classification and direction, and then I'll say, do it. And they'll do it. Or sometimes I don't even know what it is. I mean, it's like, I don't know what that is, so you can show me. And then they'll show me, and then we'll retest it, and then we'll go, son of a gun, I've been doing that for the last 5 years. And like, that hadn't been helping him. Like, you know, you probably didn't do it enough to really hurt yourself, and movement wins, but just how much of the right movement or wrong movement can you tolerate? And so I'm more than willing to let somebody give it a go. Like, here, show me what you've been doing for yourself. And you give them a piece of band, like Scott said, ER, they do it 30 times. It's like, okay, stop, rest. Okay, go back and retest motion baselines and power baselines, and it's a train wreck. And they go, golly, man, how'd that happen? It's like, and then you start talking about rapid change and key movements and avoiding certain things and stuff like that. So I'm more than happy to let someone make themselves worse in a session for sure.
I'm the same way. I'm less afraid with the extremities anyway of recovering function or having them try out the activity, because who gives you the right answer anyway? Is the patient ready or not? It's the patient, right? So even day one, if they rapidly respond and they want to go out there and run and it's a knee problem, I'd tell them, go run. It's a good piece of information for you and for me. If you do your exercises before you go out and perform the activity, and maybe mid run and after, And if he's able to do that and not fall apart, then good for him, right? So, but I mean, to stop him, we're not worried so much about neurological deficits. I'm more likely to worry about recovering function too early in somebody who presents with sciatica or arm symptoms. But in the extremities, if they get worse when they come back because they tried something, then you learn, okay, well, this requires a little bit more time to reduce before you can recover. So that's just my take on that.
Great thoughts. Let's talk about sagittal versus lateral. First question, Scott, did this patient have a relevant lateral? Is that how you describe that?
I do. I don't know if that's kosher, but I mean, I describe relevant laterals with elbows and knees being hinge joints, which the spine is a series of hinge joints, but I don't really talk, I don't think I've ever even thought, much less talked about a relevant lateral in the shoulder or the hip or the ankle. Elbow, yes, and I think knee, yes, they behave very much like the spine. So, you know, when I'm teaching, I tell people, or I say, you know, the elbow and knee are brother and sister, and the parents are the spine. So,
any other thoughts?
Very similar.
Sure. Any other thoughts on that question?
Yeah, I don't really. I guess I don't really use the term as a relevant lateral. I would just call it's an elbow derangement. It's a knee derangement that needs lateral foot, you know, extension with rotation. I don't really kind of talk about it that way. But yeah, but I don't think within the textbooks there's any reference to that. You know?
Okay. How about with a patient like Brian, and you do need to add that rotation to get full reduction? Is there a need to go back to sagittal plane and take away that rotation like we see in the spine? Yeah, I see some heads shaking no. Anyone feel like that? No, there's no need to do that. So we stay with that same reductive force.
Key movement.
Okay. All right.
Move on.
All right. Yeah.
I mean, you might end up changing direction if you don't bring about full reduction with that movement.
Okay.
Right.
But if you start in the sagittal plane and then you go off into some lateral plane, if it fully reduces and fully maintains, then stick with it.
I think back in the day when we first started doing this, I think that there was some misconception, or maybe we thought we needed to move from, like say for shoulder, from extension to functional internal rotation and to get a reductive. But I think that's not true. I think that it's one or the other of those two. And if one doesn't do it, the other might, kind of thing. I think that, you know, looking back 15 years ago, I think back in the day that might have been some misconception from some of the courses early on that, you know, okay, once I get extension, then I got to go to functional internal rotation. Well, I think that's untrue.
I will make a quick mention for everyone that is attending live. Feel free to hop in there and ask additional questions. Our panelists are here to answer your questions, so feel free to jump in and throw additional thoughts. Dave, were you going to say something?
No.
Okay. Trying to say as little as possible. I understand.
Dave's quote for the night is no.
Yeah, that's it.
That's his quote.
You can lead a horse to water, but you can't make it drink.
Oh, nice. Very good.
That's original. That's real original.
You can drop your mic, right? Let's talk for a moment about Scott's education to the patient that you're going to need to keep this up for quite some time. What do you see, Scott, that you're educating the extremity patient in terms of that reductive movement and load? How long are they going to keep doing it? To what extent? How frequently? Any thoughts?
You know, I think it's the same whether it's extremity or spine. You know, why do we see so many recurrences of spine? You know, the pain has gone away, and then the next day they go back to the typical activity and it returns. You know, the analogy I give people is, you know, burn on your skin only hurts 3 days, but it takes a month for the skin to heal. You're in the scabbing phase here. You got to keep up with it. And, you know, as they feel better, there's a natural tapering. And I think probably more so than the spine that natural tapering, they can recognize if they decrease too quickly and taper too quickly and know they have to pick it back up again. So anyways, it's just a matter of, you know, teaching them that, yeah, okay, you feel great, but it doesn't mean it's better.
Any other thoughts on that?
I normally have them continue with the reductive exercise for another, once they're reduced, so full range, full squat, full everything, and they're in good shape. I normally tell patients I want you to continue doing this exercise regularly for the next at least 3 weeks, 2 or 3 weeks. After 2 or 3 weeks, I let them start to taper, but they're tapering and self-assessing. So I've seen some patients before, they can taper off and they can stop doing the exercise and never need to do it again. Some people need to do it for an extended period of time. Some people might need to do it as an ongoing exercise, just like extension and standing for the back. And they might need to do it as a long standing. But then you just give them all the education. You know, when they present with loss of motion, they present with pain. You just need to make sure that if they start experiencing pain, they start identifying loss of motion, they've got to get back into that reductive exercise again.
Any quote for that, Gary?
No quotes.
Okay.
No.
All right. All
Good.
right.
But I think that, and I think that I agree with Dave 100%. That some people are, and I don't know who it was early on that I heard say this, Scott or Mark or someone probably, that they tend to be in thirds. Some respond really rapidly, they do well, and they don't have to do a lot to maintain it, and they're off to the races. And you got a third that will tend to respond really rapidly, but they have to do it around particular activities. And you got some people that have to do it fairly persistently for a good little while. As they push through, go through weeks or a month, or two, then they can start to taper off. But there's a variation in that, and I think the way Dave put it is that you teach the person to be that self-assessor. I mean, you're relying on them to help you.
Yeah, I was going to say the same thing. I think it's our responsibility to teach our patients to become self-diagnosticians. And so I'd look at it in terms of how quickly the derangement reduced, because you have patients who are rapidly changing. They get better really fast, and so their derangements are a lot more stable than somebody who would fall apart a little quicker with return to activity. So I'm the same way. I tell them, you continue doing your exercises for the next 4 to 6 weeks. Notice if you're starting to develop stiffness, you may not, just like we do with the spine, right? So it's the earliest sign that you're about to re-derange. Usually it's stiffness. So if they start losing motion and become stiff, then I'd tell them, go ahead and do your exercise right away, and maybe bring them on a little bit more frequently. Yeah. And so I think joints, just like, extremity joints, just like in the spine, need that prevention, just like brushing our teeth, right? So we tell our patients, even if you don't have cavities, you brush your teeth. So it's the same way. Our joints have the propensity to be in one position, just like our spine. Extremity joints tend to be in a flex position in the knees and the hips. So you want to try to do frequent performance of movement in the opposite direction to sort of maintain that balance.
Mm-hmm. Very good. We do have a question that asking if the patient did come back for a 4th visit. Scott?
No, I don't recall a 4th visit, unfortunately.
All right.
Yeah.
You must have been all better then.
Well, of course, when they don't come back, they're always better.
That's exactly right.
It was a phone call.
That's right.
They just called, I'm all good.
They turn up late or don't turn up at all, they're better.
That's right. That's how you get those good outcomes.
Exactly.
Right. Yeah.
It's like, who was it? Brian Mulligan said that his procedures are 100% effective. And someone said, how can that be? And he said, well, if they don't work, I don't use them. So he moved on. I remember him saying that. Very good. All right. So for the patient that we get back like this, and he's wanting to get back to squatting, say that was in Brian's list of things that he wanted to return to, how might you go about restoring that? Any thoughts on that, Scott? And then I'll let the panel chime in as well. Would it have been okay to start him on 3 to 4 repetitions of squat if in fact he didn't show any rearrangement? Is that too early?
Oh, I think on the 3rd visit, I'm with Gary. I get more aggressive on these things as you get older. You get less afraid of them. There'd be no reason not to check, as I mentioned before, what type of, can he squat? What type of squat can he do? Does he have to limit it partially? Does he have to, because you do get questions, you saw the video, it's a 7-minute visit. you don't even get paid your 1 unit for that, right? 7 minutes. I could have stretched it out another 35 seconds, I guess, to get that 8-minute mark. But, you know, in the real world, you know, our real world, you're seeing patients for a 15-minute unit. You're not going to be either in business or you're going to starve. So, you know, I think working with them to identify what their abilities are at the time, how to self-monitor that, how they can continue to monitor that and maybe progress on their own. That's valuable stuff. You can work with them on that rather than just saying, okay, goodbye, see you in a week.
Yeah, add additional thoughts there. Dave? No. I'll answer for Dave. No.
No.
We all got that down. Can't push a man up the ladder.
Yeah.
Very good.
People in glass houses shouldn't throw stones.
What was that? People in glass houses, what?
Shouldn't throw stones.
Oh,
that's what I always say.
So I mean, are you talking about his return to function, like returning to running?
Yeah, let's talk about it.
Yeah, I mean, again, I mean, I'm just trying to remember, because I mean, his activity that he liked to do that he wasn't able to do was running. Is that correct?
That's right.
Yeah. So yeah, I mean, once you brought about reduction, and once he can squat and he's got full range, and you squat 3 or 4 times, and he seems fairly stable. Yeah, in the clinic, I get him on the treadmill. I said, well, you know, your primary complaint was, you know, it hurts when I run. All right, let's get you running on the treadmill for a few minutes and see how that works. And if that feels okay, then go ahead and let's have you try running at home. But just turning him into that self-assessor again. It says, you know, here's what you're going to do. Is you're going to do your squat before you go for a run. You're going to do your exercise before you go for a run. Then go for maybe, I think he said it was like half a mile it was bothering him. So go run for a mile, run for half a mile. Run for half a mile, and then assess your symptoms, assess your mechanics, assess your function. If it's stable and it looks good, then go for 2 miles, and then start to return to that functional activity that he came to see you in the first place.
I stress to people that the idea is not to run to failure every time. That, like Dave's talking about, set a standard, be successful, gain confidence. You did 15 minutes, do 15 minutes. You did half mile, you did 2 miles, whatever. Do those, be successful, then build on it. So the idea is not to, you know, to run to failure or test to failure every time. Find a good start, be confident with it, be successful, move on.
Yeah.
Yep.
The question was asked, if he did come back for a 4th visit, what would you do? I'm hearing that we're probably going to address what was most important to the patient, just like you were saying, Dave, and have that patient run, retest, that type of thing. Anything else? Yeah, collect his copay. Very good.
So essentially address the functional limitation, right? So get them back to life and get them out of that fear avoidance behavior. We're all talking about drivers of pain and disability. You know, the more they move and the more that they can test themselves, and the less we catastrophize with them, the better overall. So I think that's part of that recovery of function.
I think I know what you guys might say to this, but how do you guys determine when you discharge a patient? This patient, could he be discharged after a 3rd visit? Or is it appropriate to say, all right, go and become more and more active progressively. Let me see you back in 1, 2, 3, 4 weeks, and let's understand where we are. How does a clinician feel confident that they've discharged at the right time? Any thoughts on that? Gary?
I think it's ownership. You know, I think it comes back to being well educated, having a good understanding of their issue, and being confident with what they have, and, you know, taking ownership. And so that, you know, that part of that will be, I'll kind of lay it out for them. You know, it's like, okay, I see people all the time in the same situation. They're ready to come in. They say, listen, I got this, I'm out. And you kind of, you know, that's the direction we talk about the last visit. We discuss what that might look like for the next few weeks. Some people say, hey, listen, I'm good, but I'm not, I don't know. I want to keep a little safety net. And I go, okay, I'll see you back in 2, 3 weeks, month, whatever feels good to you. Right. And then, you know, then you got a few, you just can't kick them out of the nest. And, you know, you kind of have to show them in the clinic and gain the confidence. And so I'll kind of let them help me guide that. So it's, you know, and so that's an education thing, I guess, again, where I go, you know, where are you at with this? You know, because I mean, if someone comes in, I just be honest. I mean, somebody comes and sees me 12 visits, they're not, I mean, they're not going to like me very much. I mean, That's not the idea, you know.
We're suffering through three.
I know,
occasions.
exactly.
Yeah.
Look, like 3 weeks in a row, and you guys just like, listen, we got to get done with this. This is it. It's the last one.
Yeah.
So,
Any other additional thoughts on the discharge question? Dave?
Can I just throw something out there?
Yes, please do, Cora. Help
You
us
can't
out.
push a man up a ladder. I'm just.
All
we're
right.
going to get a video of Cora trying to push Scott up the ladder.
Yeah. Kidding aside, though, I think it's important. It's part of our reassessment, right? So every time a patient comes back, we talk about how their perceived improvement. So I think asking the patient, where are you at? So if 100% is where you want to be, where do you see yourself, right? So you have your symptomatic, your mechanical and functional baseline. So you might think that the patient is not ready, but then if the patient feels that they're ready, they have the ownership. So the onus is on them to get better. So just like Brian, I'd say, so 4 visits. So what did he say? I thought it was really cool when he said, "I've got this." Didn't he say that in the video? I've got mild pain, but boy, I've got this. You know, I can get back to life. So I think asking the patient if they're ready is important. But of course, you got to take into account the motivation of that patient too. Just like Gary said, you're going to have patients who don't want to ever leave physical therapy, or don't want to ever leave the clinic.
Very good. Well, let me just say thanks again for Scott for sharing this patient case, as well as the panelists, all 4 of you. Thank you for sharing some of your time additionally during these unusual times where we have a bit more time, and participants aren't there for the in-person courses. So thanks for helping us bridge the gap a little bit with at least some good clinical reasoning discussion. Thanks everybody who's joined us this evening. We appreciate your questions and for you participating. And we'll look for other opportunities down the road where we can do something similar. But we do want to mention that you can go back and access these for the rest of this year as many times as you like. If you just want to see Scott evaluate and reassess Brian over and over, you can do that. But we're getting lots of thank yous right now, so we do appreciate you guys showing these guys appreciation. So Gary, Cora, Dave, and Scott, thanks again, and we'll look forward to an opportunity down the road to join each other again and have some more discussion. Thanks everyone.
It was fun. Thank you, Jason.
Thanks, Jason. Thanks for everything.
Thank
All
you.
right. Have a good night.
Okay.
Take care. Bye.